Hi, my name is David Kim. I'm an EP and researcher at Stanford. I'm presenting my and my colleagues' work on the association between malpractice rates and ED provider behavior. Though virtually every EP knows in her bones that fear of malpractice leads to low value, high cost care, this proposition has been surprisingly difficult to prove empirically. We were interested in how variation in malpractice risk might affect one decision we all make at least once every day, and that is what to do with low risk chest pain. In spite of the heart score and other decision tools like it, there is enormous practice variation around this question, and it struck us as the kind of relatively discretionary behavior that could be affected by malpractice rates, chest pain being the #1 presentation associated with malpractice claims. We studied a national database of ED visits in every state from 2008 to 2017. Of the 40 million or so ED visits in this sample, 2.3 million were for chest pain, and around half of those met our criteria for low risk, meaning 1, the encounter was coded with a diagnosis of nonspecific chest pain and no more serious definitive cardiac diagnosis. 2, the patient had no prior serious cardiac diagnosis like cardiomyopathy or MI. And 3, if admitted, the patient stayed not longer than 2 days in the hospital. We calculated admission rates for these low-risk encounters for every state and year. We calculated corresponding state and year level malpractice claims rates against physicians using the National Practitioner Database. It turns out, unsurprisingly, that malpractice rates vary widely across states and over time. We then looked at the relationship between the malpractice claim rate in a given state and year and the admission rate for low-risk pain the following year, on the assumption that provider behavior might be influenced by the recent local malpractice environment. As a control, we did the same analyses for acute MI, for which treatment and disposition decisions are less discretionary and which we'd expect to be less sensitive to the malpractice environment. We found in a state fixed effects model controlling for demographic composition that an additional physician malpractice claim per 100,000 people was associated with a 3.7% increase in the admission rate of low-risk chest pain the following year. By contrast, there was no relationship between the malpractice claims rate and the admission rate for acute MI the following year. This basic finding holds up under a variety of analyses and model specifications. We estimated that the discretionary admissions associated with the states and years with the highest malpractice claims rates account for at least $300 million in costs over this period and may reflect an example of malpractice-driven defensive medicine in the ED. Thank you for your interest in our abstract.